An overview of atrial fibrillation, and I will spend some time talking about wearable devices such as the Apple Watch and kind of different newer things that are going on. And so I am part of a medical group, an electrophysiology only medical group, which we feel very grateful for. My two partners, Dr. Lin Hung and Dr. Jay Tiangson, make up Mission Heritage Heart Rhythm Specialists. We're in Orange County, California. These are my disclosures. So we'll start by talking about the epidemiology and nature of atrial fibrillation, the management of atrial fibrillation, including the diagnosis, as well as the different treatment options available, drugs, ablation, pacemakers, and then we'll leave some time for questions and answers. So atrial fibrillation, let's take originates in the sinus node. You have four chambers in your heart, you have four valves, and then you have the electrical system. So as electrophysiologists, we like to think of ourselves as the electricians for the heart. Our interventional cardiology colleagues are the plumbers, and the primary care physicians are the general contractors. So it's kind of the best way to think about it. And your electrical system drives the heartbeat. Now, the brain and the heart are intimately connected. The autonomic nervous system is part of the pathway where the brain can help stimulate the heartbeat and vice versa. But your heart has its own brain. It has the intrinsic cardiac nervous system, just as your gut has its own brain, the enteric nervous system. So I like to think of us as having three brains: our central nervous system, our brain and spinal cord, our cardiac nervous system, and then our enteric gut nervous system. And it's important because, when you talk about cardiac arrhythmias or any rhythm disturbance, there is an important aspect of how the mind and the brain can impact the heartbeat and vice versa. So, for example, if you go into atrial fibrillation, your heart's racing, and it's normal to feel panic, to feel anxious, especially if you don't know what it is, if it's your first episode. So that can stimulate parts of your brain, such as your amygdala and your limbic system, your emotional centers of the brain, and put you into fight or flight. And similarly, if you're anxious, if you have a panic attack about something, that can cause your heart to race. And you may think you're having an arrhythmia, but it's not. It's actually just an elevated pulse rate related to that stress response. So we don't spend a whole lot of time talking about that kind of thing in cardiology. And I think for those of you who know me on social media or elsewhere, you know that I have a strong interest in the integrative approach to heart health, which includes mental health, social health, spiritual health, all of these things interact. So if we get back to atrial fibrillation and the heartbeat is composed on an EKG and electrocardiogram of the P wave, which is this little hump, the QRS complex, and the T wave. And the P wave is what we really focus on with atrial fibrillation. Normal sinus rhythm or a normal electrical rhythm of the heart has an organized P wave. There's a P wave before each QRS. The QRS are the electrical activation of the ventricle. So you go top to bottom, atria to ventricle. Should be a 1-to-1 activation. The heartbeat's like a metronome in music. I play guitar, so I like to think of things as musical concepts. So you should have like a metronome. Now, it's not a fixed metronome. Your heart rate goes up and down with exercise or stress or a variety of other conditions. And then the beat to beat variation in your heartbeat, which is called heart rate variability or HRV, is a reflection of how well your body and your mind are resilient. So your vagus nerve, which is part of your rest and digest response, and your sympathetic nervous system, which is your fight or flight response, that's like a seesaw, and there's a balance between the two. And so the heart rate variability or the beat to beat variation in the heart rate can change depending on what kind of state your body and your mind are in. So if you look at that individual heartbeat with atrial fibrillation, you lose that P wave. Characteristically, when you look at an electrocardiogram or your Apple Watch or any tracing of the heart, you'll see that that little hump, that organized P wave, is gone in atrial fibrillation. It almost looks more like noise. And you can see on this right side of the screen, atrial fibrillation is the lower corner, shows a fast, irregular rhythm without any consistency between beats. So atrial fibrillation, we're taught, originates from the top left chamber of the heart, the left atrium, from these four structures called the pulmonary veins. So veins and arteries in the body shouldn't have electrical tissue in them, but with atrial fibrillation, they do. And so that electrical tissue originates from the chamber itself, from the left atrium. You have these muscular sleeves that grow into the pulmonary veins. And then these have the capability of what we call automaticity, which is the cells can spontaneously beat separate from your normal electrical system. They can override the sinus node, your body's own intrinsic pacemaker, and send off AFib. So you have to imagine AFib as components of the matches, the wood, and the fire, AFib being the fire. The matches would be these premature beats that are set off by the pulmonary veins. And then if they hit the heart at just the right period, what we call the vulnerable period of the heartbeat, it can trigger an episode of atrial fibrillation. So with AFib, it's the most common heart rhythm disorder worldwide. 1 in 4 people over the age of 40 will get AFib at some point in their life, just related to age. It's like arthritis of the electrical system. You get scar tissue in your heart, just like as you would in your joints. And then that scar tissue, when it interfaces with normal tissue, creates these short circuits that results in AFib. And so approximately 70% of people with AFib will be in the 65 to 85-year-old group. And we see a lot of people with AFib that are younger, especially athletes and triathletes and people with low resting heart rates that have an active vagus nerve. The vagus nerve is found to be now a possible trigger for AFib. We see people with sleep apnea. Sleep apnea is a big one that's under-recognized as a cause and a trigger for atrial fib. And certainly, if you have a large neck, you can be at increased risk for sleep apnea, but you can have a normal neck, normal body weight, and have abnormalities in your jaw that put you at risk for sleep apnea. And then you can also have central sleep apnea, where it has to do with the brainstem's control of breathing, where you don't snore, you just hold your breath. So a lot of times people will say, well, I don't snore, I don't have sleep apnea, or my spouse or my partner doesn't hear me snore. That's not true. It doesn't rule out sleep apnea. So we have a very low threshold to check for sleep apnea in our AFib patients. So we always kind of think about these things when we see a patient with AFib, rather than just focusing on the rhythm, is the why. Why did someone get AFib? Was it related to aging? Was it related to sleep apnea? Alcohol, unfortunately, is terrible for atrial fibrillation and heart rhythms in general. And it's not just holiday heart, which was conventionally thought of as the cause of AFib in the setting of alcohol, meaning you drank an excessive amount of alcohol and it triggered AFib. We now know alcohol is a stimulant for the cardiovascular system. Alcohol has a direct toxic effect on the tissue in the heart itself. And there was a study out of University of California, San Francisco, where they actually infused IV ethanol at a microdose during an ablation procedure, and they recorded the electrical activity in the atrium. And they found shortening of the electrical refractory period in the atrium, which is a property that measures someone's predisposition to AFib. So I'm not very popular amongst my patients in some ways, but I advise people to avoid alcohol. It's like, you know what? If you can avoid another ablation procedure or a drug just by eliminating alcohol, why not? And so I think these are very important things to just kind of keep in mind, because when you have AFib or when you have any health condition, there's this element of loss of control. You feel like you're, a lot of times sort of a victim of this thing that's living within you. And it's important to feel empowered and identify what are the things that you can control. Optimizing body weight, optimizing nutrition, avoiding the toxins. These are things that are really important to know so that you feel like you have some element of control. If you look at AFib, the other thing is dementia and the association of dementia with AFib. And I just don't mean multi-infarct dementia, like from strokes, mini strokes happening from AFib, but I mean Alzheimer's. So there's an association between AFib and Alzheimer's dementia. And interestingly, there's a lot of research out of Intermountain Health at Utah where they have done a lot of database assessment of people with AFib that are undergone ablation and actually found a lower risk of dementia in patients with AFib who have ablation. I do not want to send a message on this call that ablation is the only treatment, that I'm pushing ablation. That's not what we're trying to do here. We just want to make sure that we have an overall well-balanced approach to atrial fibrillation. Not everyone's a candidate for ablation. Not everyone's a candidate for drugs. Sometimes AFib can be treated with just lifestyle changes. So it's important to keep those things in mind. The current number of Americans thought to have AFib is about 6 million to 7 million people now. And then by 2050, it's estimated to be almost 60 million people. A lot of it has to do with aging population, but also a lot of it has to do with obesity. I mean, obesity is epidemic in America, even in our young patients, and weight is closely tied to AFib. I've had people that have had multiple ablations elsewhere with us, And then as soon as they lose the weight, the AFib literally melts away. And I think again, and that can be due to not just the weight stress on the heart, but also obesity is associated with diabetes, with high blood pressure, with sleep apnea, and those are contributors to AFib. So if you look at the three things that we look at when we see someone with atrial fibrillation is stroke, heart failure, and reduced quality of life. I mean, those are the kind of the three things that we focus on. Stroke is the biggest one. And stroke, as you know, with AFib has to do with the formation of clots in the left atrium, typically in an area called the left atrial appendage, which is this remnant embryologic structure that really serves no useful purpose. It's this sort of little sac that blood can pool and form a clot and travel to the brain. And it's a little bit like your appendix. The appendix serves no useful function except to cause appendicitis. Same thing with the atrial appendage. And so we traditionally use blood thinners in certain people. We have these devices called left atrial closure devices that are like a filter you can put over the appendage. And so there's lots of different ways to manage stroke and AFib. But one of the first things that we do is we look at risk factor scoring systems. There's the CHADS-VASc scoring system, which is an acronym. Like C stands for congestive heart failure, H stands for high blood pressure, A stands for age. So we calculate the number of points in the CHADS-VASc scoring system. And if your score is 2 or higher, then you're indicated to be on a blood thinner, such as an anticoagulant, like the ones commercially available, Eliquis, Xarelto, Pradaxa, warfarin. Um, but you're also potentially indicated or option two may be available for left atrial appendage closure. Typically, if your CHADS-VASc score is 3 or higher for the closure devices. But then we have also another scoring system called HAS-BLED, which is H and A and S, all of them stand for different risk factors. And so you can add that up. So what's nice is you can actually have this sort of very academic, science-based way of assessing your own stroke risk. You can just Google CHADS-VASc and HAS-BLED, and there'll actually be a calculator that pops up on the Google search. You can plug in your own information. And so that's a useful thing to do, before you have your doctor's appointments, is that if you already know going into the doctor's appointment, this is my CHADS-VASc and this is my HAS-BLED, that saves the doctor a lot of time, because then you can have this discussion with your healthcare provider about, okay, does it make sense for me to be on a blood thinner? Does it make sense for me to have left atrial appendage closure? But there's a lot of misinformation out there about AFib, about the dangers of blood thinners, the dangers of procedures, the dangers of medications. And believe me, there are dangers, there are risks, but you have to look at risk and reward and be very careful about what you read and what you hear. Someone's experience with AFib may be very different than someone else's. And so you hear about someone who's had like multiple drugs and pacemakers and ablations and it didn't work. Well, that may have to do with the fact that the AFib had already progressed, that the size of the left atrium, which is the structure that the AFib originates from, is too large, or that person has out of control obesity or diabetes. Like all of those things will impact the success rate of any treatment intervention. When we look at the treatment of AFib, I mentioned the stroke piece, we look at the heart rate and we look at the heart rhythm. So the first thing you want to do when you have AFib is you want to make sure your heart rate's not running too fast or too slow. Because if it's running too fast, it'll weaken the heart muscle and cause heart failure. So that's why people often are put on drugs right away, like beta blockers like metoprolol or calcium channel blockers like diltiazem to help slow the heart rate down, to reduce stress on the heart. But when we look at rhythm control, all right, is this person best served by restoring the rhythm, by getting someone into sinus? There are people that we keep in atrial fibrillation. We don't focus on getting them into rhythm. Now, nowadays, we don't necessarily go to that strategy right off the bat. We try to get people in the rhythm, not just because of the benefits of the heart pumping better, but also the reduced risk of dementia, the reduced risk of future heart failure hospitalizations. But I think one of the trickiest parts about AFib is determination of symptoms. People will show up for a routine pre-op for colonoscopy or gallbladder surgery. They'll be in AFib, or they'll show up to a doctor's office. They'll be in AFib, or they get a Christmas gift and they got an Apple Watch and it shows that they're in AFib. And you ask someone, well, are you having any symptoms? No, I'm not having racing heartbeat. No, I'm not having chest pain or even shortness of breath. And then you ask someone, well, if you think about it, over the last 3 to 6 months or 1 year, have you had kind of less energy? Yeah, I have. Lots of different reasons for that. Maybe you're not sleeping well. Maybe you're on drugs that lower your energy. Maybe you've been watching too much news. Definitely does it for me. But a lot of times it's AFib because the atrium contributes about 20 to 30% of the pump efficiency to the heart. So when your heart loses that pump efficiency, it will often show up as just fatigue or I just don't feel good. And the problem is, just like arthritis, like if you had a bad knee, right? You park closer and closer to the front of the grocery store. You just kind of adjust. You adjust your life. So you don't really think about the arthritis impacting you necessarily. Same way with AFib. You may feel this progressive fatigue, not necessarily think it's your heart, because it's not like a blocked artery where you get chest pain. AFib can be really subtle, really sneaky. And so it's not until you restore someone's rhythm that they realize, oh my gosh, I feel better. I had one gentleman, his only symptom of AFib was depression. And when we restored his rhythm, he had better blood flow to his brain. He had more endorphins, dopamine levels were better. And so he felt better. So I think it's important to think of the heart as interconnected to every aspect of the body and really just to think about the fact that the absence, quote unquote, of symptoms doesn't mean someone's not having true symptoms. And you often don't know until you restore the rhythm. So when you look at the types of AFib, I use the comparison to cancer not to scare people, but I use the comparison to help one understand a framework for how to look at this disease because it is a progressive disease. And early on, it's called paroxysmal, where you go in and out of it. Your body's able to correct. That's kind of like early onset cancer. We can just cut out the tumor. But then later, the heart is a muscle. So it gets a muscle memory, and every beat of AFib creates a muscle memory for more AFib. And when I say muscle memory, I mean at the cellular level, there are changes in the way the heart's electrical system connects so that it makes it easier to have more AFib. So if the AFib is going on for several days, if it's going on for several weeks, if it's going on for several months, it becomes persistent. It becomes long-standing persistent when it's been continuous for over a year. And then it becomes permanent when no matter what we do, we can't get someone into sinus rhythm. So each stage of AFib is treatable. There's hope at each stage. Okay. It's not that, oh my gosh, I can't get into sinus rhythm. That's all that can be done. There's always an importance to focus on quality of life, no matter what stage you're in. And if someone's in permanent AFib, maybe the focus is just controlling the heart rate. Maybe the focus is on preventing stroke. But as electrophysiologists, we do have a mission and a goal to try to keep people in rhythm if we can, if the heart allows us to, because we strongly believe that the heart pumps more efficiently in sinus rhythm. But life is not over if you're in continuous permanent AFib. There's lots of different ways to still manage the condition. And you're not an AFib patient. You're a human being that happens to have atrial fibrillation. And that it's a real pet peeve of mine when we use terms like, oh, this AFib patient. No, it's a human being. You have this condition. And by the way, if you have AFib, you're in the company of Larry Bird from the Celtics. You're in the company of Arnold Palmer. You're in the company of lots of different famous people, to be honest. George H. Bush, Billie Jean King. These are all different people who had atrial fibrillation. So it can affect any of us. And I think that's an important, just like cancer can. So if we look at the AFib when it first presents as paroxysmal AFib, first episode of AFib, the statistics show within a year from that first episode, a person, 1 out of 5 people, will go on to get persistent AFib. And that's really important because, this is not to knock, primary care physicians or cardiologists, but historically, we have not done a good job at educating people about the seriousness of this condition. Oh, 1 or 2 episodes a year, no big deal. Every episode creates a muscle memory for it. And you can't predict necessarily who's going to get persistent AFib and how quickly it's going to be. Someone may have AFib for only a few weeks and it goes persistent. And some people may have AFib going on in and out of AFib for years and it never becomes persistent. And there's different reasons for that. But it kind of comes down to common sense. When the body's in balance, when weight is optimized, when you're not taking in toxins like alcohol and tobacco, when stress is managed, all of these things, then the heart responds. The heart responds to these things and it regularizes its rhythm, it normalizes its rhythm. And we don't do a good job about talking about that in Western medicine. But the reality is that you have to treat all aspects of the heart. I mean, I can't tell you how many people who are in AFib and they're heading off to the emergency room, they convert to normal sinus rhythm when they hit the waiting room. Or they convert to normal sinus rhythm as we're really getting ready to cardiovert or shock the patient. And my hypothesis is that when you're in a safe place like a hospital, even though a hospital is a scary place, when you're in the hospital and you know you're going to get treatment for your AFib, all your stress hormones calm down, and the stress hormones and adrenaline trigger more AFib. So you can convert to normal sinus rhythm in that environment because of the calming that occurs in your sympathetic nervous system. So why do I say all that? It's because I counsel my patients, learn mindfulness, learn meditation, journal, do yoga. There's studies on patients with pacemakers showing a lower risk of AFib if you do yoga. There was a study out of Kaiser that showed that. So it's not woo-woo kinds of stuff. This is legitimate science that's showing that if you manage the mind, you will help the heart and vice versa. So with AFib, lots of ways to diagnose. Traditionally, we have heart rhythm monitors, patch monitors, wired monitors. We have implantable monitors. And then, of course, you have over-the-counter devices like CardioMobile and Apple Watch. The over-the-counter monitors like CardioMobile and Apple, they're actually pretty good. And they have about an 85 to 90% ability to detect AFib. The most common reasons why you'll get an inconclusive or indeterminate reading on an Apple Watch or CardioMobile has to do with either the electrode contact, if your fingers have oil, or if you have a little bit of a tremor and it's not resting on a very stable surface, you'll get this noise and then the device can't interpret it. Or if you're having premature beats. So if you're having premature atrial beats from the top chamber, or you're having premature ventricular beats from the bottom chamber, that the algorithm for these devices is using the intervals between heartbeats. So if you're having a lot of premature beats, it'll think it's AFib. So just keep that in mind, that not all readings that are indeterminate. I've even seen cases where the devices call something AFib and it's not AFib. Now, if it calls something normal rhythm, my experience has been is most of the time it is normal rhythm. So seeing that normal sinus rhythm is a nice reassuring finding. The risk factors for AFib, I touched on a lot of them. The athleticism I mentioned is kind of this newer risk factor we've identified. Premature atrial contractions or PACs. So we used to tell people, oh, they're benign, no big deal. That's not true. So studies have shown that if you have a high percentage of PACs on an outpatient monitor, like a 24-hour Holter, that's an independent risk factor for getting AFib. So we do focus on reducing those premature beats because I use that idea of the fire. AFib is the fire. Premature beats are like the matches you're throwing at the fire. So if you have enough of them, it's just a matter of time. And when I use that sort of metaphor of the fire and the wood, if you imagine the risk factors as the wood, and like if the weight gets out of control or the diabetes gets out of control, that wood is getting drier and drier and it's kind of forming a kindling. So that's how all these things come together to create that first episode of AFib, that perfect storm. People often think, I was feeling fine and this AFib came out of nowhere. No, it doesn't come out of nowhere. These changes in the electrical system happen over time at a silent level, And that's why it's good to have these wearable devices available. Any kind of heart disease can be a risk factor for AFib, whether that's coronary disease, valvular heart disease, congestive heart failure, thyroid. If you have an overactive thyroid, Graves' disease, that can be a risk factor for atrial fibrillation. All of these different facets come into play. High blood pressure is one of the number one risk factors for atrial fibrillation. When you think of risk factor, that's like the wood. Triggers are like the matches. So I mentioned the premature atrial beats. Stress is not a risk factor for AFib, but it's a trigger for AFib. So certainly if you are stressed and you're medicating with alcohol and you're not sleeping well, that's the perfect storm to get an AFib episode. So it's really important. We have really started to realize the importance of sleep hygiene with all health issues. And we see the same with AFib. So getting a good night's rest, tracking your sleep, whether it's with a device or whatever way you do it, is really, really important because it's going to help your overall health as well. Exercise is interesting. So AFib tends to occur when you're at rest. That's why it occurs in the evenings or in the middle of the night, or if you have sleep apnea. That's because the heart rate slows. And when the heart rate slows, it's easier for the premature beats to kick in. It's not that common for AFib to occur during the day when you're out and about because your own sinus node, your own heartbeat, suppressing the AFib, suppressing the chances of having AFib. Now, there's a subset of patients who have exercise-induced AFib, where they go into AFib when they exercise. It's not a very common percentage. Interestingly, vagal AFib that has to do with that low heart rate, you can terminate AFib when you exercise. I had a firefighter who, when he went into AFib, he would run up and down the stairs and it would stop his AFib episode. And that's because that is actually bringing out your sympathetic nervous system when you're exercising and it's stopping your parasympathetic. So it's interesting, there's all this talk about the vagus nerve and the great thing about the parasympathetic nervous system, it calms you, improves your heart rate variability. But in AFib, too much of a good thing is not a good thing. So if the vagus nerve is overactive, if the heart rate's too low, then it can be a problem. Now, when you talk about treatments for AFib and people talk about pacemakers, I just want to be very clear. Pacemakers do not treat AFib. People who have AFib can often have tachybrady syndrome, tachy meaning fast, brady meaning slow. They can alternate between fast and slow. That is a case where you may put in a pacemaker to treat the brady, the slow, and then you do something to treat the fast, whether it's a drug, whether it's an ablation. There are a subset of pacemakers made by certain companies that have algorithms to detect these premature beats and suppress them. They're AFib suppression algorithms. There are pacemakers that have what's called antitachycardia pacing that can deliver electrical stimuli that you don't feel during AFib to stop AFib. And they have modest success rates. So there are a subset of pacemakers that can be used as adjuncts to treating AFib, but by and large, pacemakers, there's usually an indication of a low heart rate. Like usually that's a part of it. And then the other category of people who get pacemakers are people who have AV node ablation, which we can touch upon shortly. One thing I'll also say about the vagus nerve is sometimes very large meals, fatty meals, can be a trigger for AFib or acid reflux. The esophagus is right next to the left atrium, so you could have bad acid reflux triggering the AFib and vice versa. So again, keep a diary, keep a log, do that detective work. Okay, I went into AFib. What was I doing in the past 24 hours? Did I not sleep well? Did I have something to eat? I mean, it's amazing how these subtle little things that you discover. I had one guy who had a gluten allergy and it triggered PVCs. So it's important to just kind of think about these things when you're thinking about the AFib. And, one of the hardest things for people is to give up alcohol because it's such a social thing, right? I mean, people bond. And I tell people, I say, your friends may want to, have you have that glass of wine or that beer, but they're not the ones on the ablation table. So if stopping it will help prevent another procedure, just do that. No, just do that. So if we look at the treatment of AFib, cardioversion or shocking the heart back into rhythm, that gets someone into rhythm. Okay. It's not a treatment for preventing the AFib from happening again. It's just turning your computer on and off. If the wires are broken in the computer, they'll break down again. So there's usually something that needs to be done with the cardioversion, meaning some kind of medication adjustment to prevent AFib, or if it's triggered by sleep apnea or alcohol or something else, or high blood pressure, then treat those things and maybe that'll prevent another AFib episode. But if you really want to treat the AFib itself, you got to go after the matches, the wood, and the fire. And that's where things like drugs and ablation come into play. And so with drugs, there's rate control drugs, just focus on controlling the heart rate, beta blockers, calcium channel blockers. They don't really prevent AFib. They're really designed if you go into AFib to prevent the AFib from going too fast. There may be a little bit of a benefit in preventing AFib in that they can help suppress the PACs from triggering AFib. And then you have this other tier of drugs called antiarrhythmic drugs like flecainide, sotalol, propafenone, amiodarone, Maltac, dofetilide. These are all different ones that we have. They work on different ion channels in the heart. And by and large, even the most potent one, which is amiodarone, has a success rate long term of around 50 to 60%. So there has not been a good drug for AFib that's been developed in decades. The cardiovascular system, the electrical system is really complex. It's not like cancer where you can identify a receptor mutation in a breast cancer gene and then create a drug and immunotherapy to target that gene and target that tumor. We don't have something like that for AFib. There's been some research in drugs that work just on the atrium, but most of the drugs, most of the antiarrhythmic drugs, have effects on the ventricle too, which is why they're associated with risk of sudden death, risk of lung toxicity, like with amiodarone. So there's a role for drugs, don't get me wrong, but that's why most of the research and development for AFib treatment has gone in the realm of ablation, because you're getting at the heart of the problem, no pun intended. You're getting at the broken wires. Ablation is like sealing the insulation around the broken wire. Antiarrhythmic drugs are like duct tape. They may work for a while, but then they stop working. Now, am I biased towards ablation? Of course I am. I'm an electrophysiologist and I do ablation. So I'll be very honest with that. It's not meant for everyone though. But one of the things that we want to discuss today is some of the newer technologies such as pulse field ablation. So if you look at ablation and you look at its origins, first AFib ablation was done in the mid-90s by a French electrophysiologist, Michel Hassaguer. And he discovered that these premature beats from the pulmonary veins were triggering AFib. There was a New England Journal of Medicine article that was published back in the mid-90s. And the ablation procedure has undergone multiple iterations over time. And so if you look now, especially with pulse field ablation, for a paroxysmal patient, you have a success rate of around 80 to 85%, sometimes as high as 90%. For persistent, that's gone up now to about 70%, sometimes even 80%. Now you'll hear different numbers. Your different doctors will quote different studies will quote different numbers. So you got to keep in mind that every day of normal sinus rhythm after a treatment like ablation or a drug or a cardioversion, that's a good day. And so try not to think of percentages, try to think of long-term freedom of recurrence from atrial fibrillation. So if you look, and then how do you define success? So some people define success as the absence of symptomatic episodes. Some people define the success as no AFib. But in the end, it's really about quality of life. And that's the definition. So some people will have an ablation and they may still have AFib, but the episodes are less frequent or less intense. So those are just things to keep in mind. So radio frequency or heating of the circuits and destruction of tissue, that's been around for decades. And then came cryoballoon, which is freezing technology, and they still have their role. But one of the problems with those technologies is that they don't distinguish heart tissue from tissue outside of the heart, such as the esophagus, which is right next to the heart, and the phrenic nerve, which innervates the diaphragm muscle. So those technologies can injure those structures, not often, especially if properly monitored, but they can. And if they do happen, especially the esophagus causing a fistula, it can be life-threatening. So this is why pulse field ablation was invented. It's the holy grail of catheter ablation. Pulse field ablation uses, rather than heating or rather than radiofrequency or cryo, it uses electroporation, which are these microelectrical pulses that create these micro holes in the cell membrane to destroy the cells. And it's very tissue specific, meaning the energy signature for these pulses, the scientists over the years have worked on this, just work on cardiac tissue, but don't damage the esophagus or tissues outside of the heart. Now, there are some reported cases of spasm of the coronary artery in certain areas of the heart that you do pulse field ablation. So that's an important thing to talk with your doctor about if this issue comes up, is spasm of the coronary artery. But as long as you take certain precautions, then that risk is relatively low. We're still learning about it, though. I mean, it's a good thing, but we don't have like 10-year, 20-year studies. So that's also important to keep in mind. But the studies that we do have definitely indicate safer procedure, faster procedure. As far as efficacy goes, there is some data that shows there may be a greater efficacy compared to the standard ablation treatments. But most electrophysiologists have switched over to pulse field ablation because of all the benefits that I mentioned. And so, and especially for persistent AFib, because with persistent AFib, we often have to ablate areas outside the pulmonary veins, like the posterior wall of the back part of the heart. And that's right next to the esophagus. And that's what was the limiting factor in us ablating persistent AFib before, was worried about damage to the esophagus. But with pulse field ablation, we don't have that concern. So we're able to properly treat the patient. Because in the past, if you did an ablation and there were areas that were near the esophagus that you couldn't ablate, that those areas would grow back and trigger AFib. That's why you didn't have success. That's why you had recurrence. So the studies are showing now with persistent AFib, because we can safely ablate the posterior wall, we're having better results. So we have different companies out there that make different kinds of catheters. And so Medtronic, for example, makes the Pulse Select catheter, which has like this lasso configuration to it that emits the pulses. We have Medtronic came out recently with the Affera system, which is more like a ball, like a lattice work that creates these three-dimensional maps. And the Affera system allows you to deliver both pulse field and radio frequency. It's a dual energy system, and there's advantages to that. And most of the technologies are moving towards that. So rather than having, okay, I got a radio frequency, I got a cryo, I have a PFA, can I construct a catheter that has multiple technologies built into it? And then Boston Scientific has the Farapulse catheter, which comes in these different configurations, basket and flower, which is a really nice technology to use too. These are one-shot ablations. So like, for example, with radio frequency, you have to do this point-by-point ablation, which is very tedious, and you can have gaps. Whereas with pulse field ablation, it ablates all the tissue at once, and you kind of rotate the catheter. Less chance for gaps, lower chance of recurrence. And so with regards to comparison between ablation and drug therapy, vastly different outcomes. Ablation, much higher success rate. And then you look at the risks. The overall risk with an ablation procedure is in the 1% to 2% range. And if you look at things like risk of stroke, as long as you're on a blood thinner before and after the procedure, that risk is relatively low. And then if you look at risk of like trauma to the heart, emergency heart surgery, proper imaging, a physician who has a lot of experience, a hospital who has a lot of experience, those risks are relatively acceptable, to the point that there's been studies that have shown that patients in their 80s, octogenarians, have better outcomes often with ablation than they do with drug therapy, because drug therapy has a greater chance of drug-drug interactions. As we all get older, our kidney and our liver function declines. These drugs are processed through those organs. There's a greater risk of toxicity. There's a greater chance of polypharmacy, multiple drugs as you get older. And so it would make sense that if you can do an ablation to get rid of drugs, that you would have actually a safer profile. I've even done people in their 90s, if they're functional, if they don't have a lot of medical problems. The anesthesia that we use now, the procedure for ablation is about 90 minutes now. When I started doing ablation in 2001 at Stanford, it was like a 8 hour procedure with a 40% success rate. So it's come a long way. But yeah, if you look at the risk reward with these kinds of treatments, it's definitely there. And I would just say that, as far as reaching out to people and I would encourage you to go to places like myfastheartbeat.com, get smartaboutafib.com. I have a lot of this information on my website. My website's draseemdesai.com. But there's a lot of resources that you can get more information about AFib, about these different technologies that we have. So I would encourage you to do that. The mapping that we do during an ablation procedures is pretty amazing. We have these catheters at multiple electrodes. It's almost like an artist creating a paint canvas where we can record these colors. You can do a before and after map when you do the ablation to see that the signals are limited. So there's an actual real way to tell that you were successful in the procedure. It's almost like we're chasing these tornadoes and we can actually track them down pretty amazingly. And so when we look at the convergent procedure, that's another technology that's used. Very effective for people who have been in AFib for years. is very effective, where you ablate the back part of the heart. The surgeon ablates the back part of the heart through scopes. And then about 6 to 8 weeks later, electrophysiologist comes in, ablates from within the heart. So it's a hybrid procedure. The Wolf mini maze, there's other procedures out there that are surgically procedures. But I will say PFA has probably superseded a lot of this because the convergent ablation uses radiofrequency ablation, but there's still a role for it. Still a role for it. And the maze procedure is a ablation done during surgery, like if you have valve surgery or something, that because there's AFib is very common in people who have heart surgeries. So that's why often you'll see a surgeon do ablation. But it's very important to realize that a high percentage of strokes are due to AFib. And a lot of times we don't realize that person comes in the hospital with a stroke, rhythm is normal, but that doesn't mean they didn't have AFib at home. And so there's this thing called cryptogenic stroke, which is stroke of unknown origin. With the monitors we have now, with the implantable monitors, we've learned a lot about that in many cases it's due to AFib. So it's important, if you have a stroke, you know someone who had a stroke, to make sure that atrial fibrillation was ruled out. So in summary, AFib is a condition that's very manageable, that I would definitely encourage a integrative approach. You want to focus on your nutrition, your Mediterranean diet, your sleep, optimization of weight. You want to focus on stress management, mindfulness, yoga, Pilates, core work, like all of this stuff is really, really important. And just realize that you're not alone. I didn't show a lot of slides on the left atrial closure devices, but just to kind of talk about it, you have Watchman, you have AtriClip, which is done during a convergent procedure. Lots of great safety data about these. We now do combined procedures where we do the ablation and the Watchman in the same procedure, so that's an option. There's some data showing that when you close the left atrial appendage, you may have a lower chance of AFib. But closing the left atrial appendage is not designed to stop the AFib. It's designed to get you off a blood thinner. And it has a pretty broad indication, meaning that a high percentage of patients are candidates for the procedure. Now, it's definitely better than blood thinners in terms of a lower bleeding risk. But as far as like protection against stroke, it's still felt to be relatively equivalent in terms of its protection. So we can't really sit here and say, oh, get a Watchman because it's better than the blood thinner you're taking. We're not quite there yet. But it is increasingly clear that because a lot of patients with AFib are older and have balance issues or fall easily or predisposition to bleeding or maybe have coronary stents and are on blood thinners already, that they would benefit from something like a closure device.